Hi, and welcome to the March 6th, 2013 Plastic Reconstructive and Cosmetic Surgery Journal Club here from St Vincent's Hospital in Sydney. I'm Damien Marucci, I'm a plastic and reconstructive surgeon. This is Dr. Lisa Luo, who's currently one of the unaccredited registrars at St George Hospital in Cogra. So, Lisa, what were the papers we did this evening?
Okay, so the first paper today was looking at the ideal split skin graft donor side dressing, and this paper compared an aquacel dressing with a modified opside dressing where they perforated the opsides and put gauze over it.
Yeah. I thought this was a really well designed paper. It was a randomized, double blind, controlled trial where one half of the same wound was treated in one way and the other half of the same wound was treated in a different way. And then what about the outcome measures?
So they were all very statistically significant. It showed that the side dressed with the modified opside had increased epithelialization rate at day 10 when the dressings were removed, less pain throughout the whole period, and also at day 10 of dressing removal. And also it costs 4 times less compared to the aquacel dressing, so it seems like it's a good option to use clinically.
Yeah, certainly there are many different things that people use to dress split skin grafts. I've tended to use Caltastat, mainly because that's what most people in Sydney use. I know overseas, places I've worked, they use sterile hyperfix dressings. Aquacel is certainly being pushed as a good donor side dressing, but just using an opsite which has been perforated with a 20 gauge needle at 1 centimetre intervals and then just having a dressing over the top which you can change easily resulted in a reepithelialization rate of around 85%, I think.
That's right.
At 10 days, which was statistically significantly better than the aquacel. And I think at the Journal Club everyone recognised this as being a very good scientific paper, and it was widely appreciated. Is there anything else about this?
Yeah, I guess the main thing is that Caltastat is used in a lot of units, and the concern was if they changed to an opside dressing that nursing staff may not be used to it initially, and that was the concern.
Yeah, there will be a learning curve.
Yeah.
Yeah, okay. All right. Okay, now the next 2 papers have to look at fascia sparing abdominoplasty. So the first paper was the classic paper, which was the Lipoabdominoplasty paper from Saldanha, which was published in PRS a couple of years ago. Saldanha is a Brazilian surgeon who was unhappy with the seroma rate following a typical Patangi style abdominoplasty, and so in about 2001 transferred over to a lipoabdominoplasty. This technique involves a wet tumescent technique initially, and then liposuction is performed on the entire abdomen, including underneath the area of skin which is due to be resected. In the resection of the infraumbilical skin, Scarpa's fascia is preserved, and then a tunnel is made from the umbilicus up to the xiphisternum, and the lateral edges of the tunnel are defined by the perforators, the medial row of perforators, through the rectus abdominis muscle. So the idea is that 80% of the blood supply to the skin of the abdominal flap has been preserved. And he said that he had a significant decrease in his seroma formation, and that patients were very happy with the final cosmetic result. This paper was looked at in conjunction with the new paper, which was Scarpa fascia preservation during abdominoplasty, a prospective study, and this is from Portugal, published in the current PRS. What was the gist of this paper?
Okay, so in this paper, it was done at a single centre, 2 different teams. One team did the classical abdominoplasty by Patangi, raising the whole flap, whereas the other team only preserved Scarpa's fascia infraumbilically, and they looked at drainage rates, so total drain output, time to drain removal, and total length of hospital stay, and that was all significantly reduced in the group that preserved Scarpa's fascia.
And so the idea is that by preserving Scarpa's fascia, you preserve the lymphatic drainage from the lower part of the abdomen, thereby decreasing seroma rate. Also, there's a nice sort of soft tissue bed which the abdominal flap can sit on. The patients still need drains, but drainage was significantly less and the time to drain removal was significantly less. What did people think about this paper?
So people thought that the paper was very well done. It had good outcomes, and also it was a good way of confirming what people suspected already, that Scarpa's fascia preservation was a good way of reducing survival.
One of the issues raised, which you brought up, was the fact that it was two separate teams doing the surgery. It wasn't like you had single surgeons who were randomised to do either a Patangi style or a Scarpa fascia sparing abdominoplasty. There were surgeons who only do Patangi style, other surgeons who only do Scarpa's fascia sparing. So that means it's that sort of decreases slightly the objectivity of the study, because obviously they're all going to have their particular strengths and weaknesses in doing particular techniques. But overall, it seemed to confirm what Saldanha spoke about in his paper, and other authors such as Lalawan spoke about in their abdominoplasty techniques. All right, the last paper was volumetric analysis of fat graft to survival in breast reconstruction. When was this from? This was from PRS last year or this year?
Last year.
Last year PRS. And so what was the...
So this one, they used 3D imaging techniques and looked at breasts that have been fat grafted, and they classified them in different ways. The main one was looking at breasts that had different amounts grafted in them. So the smallest amount having an average of 50, the medium amount having an average of about 90, and the larger grafted amounts having an average of about 150 cc's. And looking at the graft loss over time. So they did the 3D volume analysis at pre-op, day 7, 16, 49 and 140 post-op.
And this is one of the interesting parts of the paper, was the 3D volume analysis was done using a 3D camera called the Vectra, is the brand name of this particular camera used in this study. And the idea is that it's a non-invasive way of estimating volume, and you can also look at things like symmetry and the like. And so by using the Vectra preoperatively and then comparing it with various time points postoperatively, they were able to look at the percentage of fat graft survival going forward. And what were their results?
So surprisingly enough, the results showed that in the larger volume grafts, there was an initial quite a significant decrease in graft take, and then it steadied out quite quickly. And overall, they had the largest amount of percentage retention of the fat, whereas in the smaller groups, it took longer for the fat to stabilize, and they retained a smaller amount.
Okay. Well, there are a few things about this paper. One of the issues was that the authors made no attempt to explain why, surprisingly, larger volume fat grafting resulted in a higher percentage of fat surviving. Because intuitively you would think, you know, Coleman's teachings using very small amounts of fat in small tunnels, that using smaller volumes of fat would, you would think, lead to more reliable fat graft take, whereas this study didn't show that.
So they also looked at several other groups. So one looking at irradiated versus non-irradiated breasts, found no difference in terms of fat loss, and also the difference in previous surgery. So lumpectomy, autologous reconstruction, as well as implants. And again, there was no significant difference.
Yeah. So the only place where they did find a significant difference was when they divided the volume, where they stratified the volume into small, medium and large. I got the impression that that was a post-study evaluation. It wasn't like as if they said, well, let's compare small, medium, large. I got the impression that they looked at all the volumes they put in, and then they looked at radiotherapy versus not radiotherapy and didn't find a difference. They looked at fat grafting for lumpectomy versus fat grafting for an adjunct to autologous reconstruction, didn't find a difference. And then when they put the numbers in for small, medium and large, bingo, they found a difference. That's not to say it doesn't exist, but it is a post hoc kind of analysis which has been done. But certainly the Vectra, and this is something they spend a lot of time talking about in the discussion part of the paper, is a very powerful tool, and I'm sure will appear with increasing frequency in the pages of the journal as being a means of assessing volumetric differences before and after, and also a means of assessing symmetry.
The only problem with that one was that it was difficult to tell whether which part of it was the edema from the surgery and which part was the actual fat loss. And also another concern with the study was that the volume changes haven't settled out by the end of the study, which is at 140 days. So it would be nice if they continued it on. Yes,
because really, ideally, you'd want the study to continue until they showed when the fat grafting volume became stable, because at the 140-day mark, the volume was still decreasing. And so if they could take it out longer, then we'd be able to tell our patients, we'll do fat grafting now, I'll put in 100 cc's, and I know that in 6 months' time, you'll still have 50 cc's, and in a year from now, you'll still have X number of cc's. That would be very valuable clinical information. Okay, well, I think that's it. Lisa did a fantastic job this evening. So for those of you who were there, thank you for being there. And for those of you watching now, thank you for listening. Good night.
Good night. Thank you.